the advantages of standardization in the care of endocrine surgery patients. This will be presented by Dr. Maria Albuja Cruz, who's an associate professor in the GITES division. She did her medical training at Pontificia University in Quito, Ecuador, and then came here for her general surgery training, left us for a period of time and went to the University of Miami to do a endocrine surgery fellowship. She's been on faculty as long as I've been on faculty here since 2012. And I have really enjoyed working with her. She is an excellent clinician. She is very dedicated to teaching and has won Teacher of the Year award here and organizes many educational events such as the mock oral surgery boards. She is administratively talented, has really done a tremendous amount in reorganizing our templates for outpatient clinics, very involved in safety and quality initiatives, and I and the rest of the crew really appreciate that. With that, Maria, we really look forward to your talk, and please go ahead.
Are you able to see my screen?
Not yet. Oh, something's happening. Hang on. Yes, we can see your screen. Okay, we have your presentation mode. So if you have two screens, select the other screen.
Okay.
The best way to do is just end show and start it again. And Maria, if you end share and just start again, and then it'll give you an option of which screen.
Okay, let's see if that works now.
Perfect. Done.
Thank you, Dr. Schulich and Dr. McIntyre, for the opportunity to present today. And I also would like to thank you, Dr. Kukrisha and Dr. Kambler, for setting the stage for my presentation with their great review they have today about quality improvement in surgery. And in this presentation, you will be able to see the application of Plan, Do, Study, Act framework for the improvement in the care of the endocrine surgery patients. The objectives of this presentation are to analyze the protocols implemented in our endocrine surgery practice, summarize the outcomes since implementation of the endocrine surgery protocols, and identify areas of improvement in the care of endocrine surgery patients based on the outcomes of the implemented protocols. Hypocalcemia owing to the inadvertent devascularization or removal of the parathyroid glands is the most frequent complication after total thyroidectomy, and it occurs in 20 to 50% of our patients. Development of a hypocalcemia can result in longer patient hospital stays or visits to an ED, and is the principal predictor of the duration of in-hospital stay after surgery. The social, emotional, and physical cause of symptomatic hypocalcemia requiring aggressive supplementation, repeat biochemical evaluation, and possible hospital readmissions are considerable. There are various strategies to predict, diagnose, and management hypothyroidectomy hypocalcemia, as the routine supplementation with calcium and vitamin D, the supplementation only if symptomatic hypocalcemia is present, supplementation based on laboratory calcium level results, or supplementation based on PTH levels. However, there is no standard guidelines in the optimal algorithm for its management. Prior to the introduction of the hypocalcemia protocol, it was our practice to routinely give calcium supplementation to all our patients, plus minus calcitriol, and the decision for the calcitriol was based on attending choice. Sorry. The goals of the implementation of hypocalcemia protocol were to standardize the management of hypocalcemia in our practice, and also to reduce symptomatic hypocalcemia, the need of IV calcium, and unnecessary calcium supplementation, and also help us recognize which patients are at risk in order to provide closer supervision and to initiate early supplementation therapy, and at the same time help us to identify those patients who are at low risk to allow a safe earlier or same-day discharge. Based on the review of published data on the management of hypocalcemia and the utility of post-operative PTH levels to predict hypocalcemia, we developed our hypocalcemia protocol in conjunction with our endocrine colleagues. Dr. Bodov Jess was the endocrinologist champion for this project. The protocol included the creation of 3 algorithms that guided the PACU and in-hospital management of hypocalcemia, as well as discharge and follow-up instructions, and a winning protocol of calcium and calcitriol. This is the immediate post-thyroidectomy algorithm, which stratifies patients into 3 different risks of developing hypocalcemia: high, moderate, and low, based on the results of PTH, calcium, and albumin levels checked as soon as the patient arrived in the PACU. The therapy that the patients will receive will depend on the risk of hypocalcemia that they are stratified in. Patients in the high risk will receive calcitriol and calcium. Patients in the moderate risk will only receive calcium supplementation, and patients in low risk will receive no supplementation. Patients will be admitted to the hospital for close monitoring of calcium levels, which were going to be checked at 10 p.m. and 6 a.m. The 10 p.m. algorithm shown in this picture dictates the management of patients based on corrected calcium level drawn at 10 p.m. and also accounts for patient symptomatology. The 6 a.m. algorithm is based on the corrected calcium level checked at 6 a.m. on the morning and also is based on the patient's symptomatology. This algorithm aids to identify the patients who are ready to go home and also displays what type of medications patients should discharge with, and also identifies those patients that need continued monitoring. The successful implementation of the hypocalcemia protocol and the transition from our old practices required the support and buy-in of all our partners, endocrine surgeons and endocrinologists, to use the protocol. Education about the new protocol, which was achieved by providing launch and learn educational sessions for surgical nurses in the ward, introducing the protocols during intern orientation week, and also educating the surgical residents monthly during our Rhino conference. Also, it required that this algorithm have easy access to residents, and this was accomplished by creating in small laminated cards with the algorithms for the resident learners. We also created posters that were displayed in the residents' call room and workstations in the hospital, and the protocols were also added to the Rhino book, which is shared with the residents on their start of the endocrine surgery rotation. We also align the order sets in EPIC with this new protocol. And importantly, was the close monitoring of the adherence to these new protocols by daily review of admission and discharge orders, and also providing immediate feedback if any deviation for the protocol was identified, to assure the understanding of the new protocol, and also to obtain information on the possible variants for compliance that will need to be addressed. To evaluate the performance of this protocol, we compare 120 patients on protocol with 195 patients the year prior to the implementation of the protocol, and found that after the implementation of the protocol, there was a significant reduction in hypocalcemia events, the need of IV calcium drips, and the need and the decrease of the calcium supplementation. Furthermore, the protocol accurately identified those who benefit from closer monitoring and immediate supplementation, which, as stated before, reduced the development of hypocalcemia and IV calcium, while identifying patients who do not require calcium-directed therapy avoiding needless supplementation and additional monitoring. 50% of our patients in their practice landed in this group and became the natural target for outpatient thyroidectomy. Total thyroidectomy has historically been performed as an inpatient surgery. Patients were admitted to the hospital due to associated risks of life-threatening complications, including hypocalcemia and airway obstruction, either due to bilateral recurrent nerve injury or neck hematoma. The economic environment of modern healthcare is compelling hospitals to control costs while maintaining and improving outcomes. Because of the high cost of inpatient care in the United States, that arose predominantly from bed and nursing charges, much attention has been paid to both reducing the length of hospital stay for inpatient procedures or shifting elective operations to the outpatient settings. And thyroidectomy is not the exception. Maximizing the efficiency of critical hospital resources may instead be reallocated to other important needs. Published studies have demonstrated the reduction in charges associated with outpatient thyroidectomy compared to inpatient surgery, with approaches to $2,500 per encounter. Thyroidectomy is now frequently undertaken as an outpatient procedure with several peer-reviewed reports of safety implementation. Also, many patients prefer outpatient surgery from a comfort and convenience perspective. Convalescence in a quiet, comfortable, and familiar setting for supporting family and friends may be preferable to a less quiet, interruptive, and unfamiliar hospital environment. The American Thyroid Association published guidelines that stated that outpatient thyroidectomy may be performed in carefully selected patients, but there are no consensus on the selection criteria for thyroid surgery. The aim to create an outpatient thyroidectomy protocol to allow us for a same-day thyroidectomy surgery, also to help us recognize patients that needed admission for close monitoring while identifying those that can be discharged home the same day. In the creation of the outpatient thyroidectomy protocol, we developed an outpatient thyroidectomy candidacy criteria tool to select patients that are candidates for outpatient thyroidectomy. This tool incorporated different factors found on the literature review to increase the risk of complications after thyroidectomy. These included patients' age more than 70, social factors such as the distance to a hospital, living alone, on the willingness to follow instructions, comorbidities such as obesity, obstructive sleep apnea, respiratory failure, renal failure, seizures, the use of anticoagulation therapy, and also thyroid pathologies such as large goiters and retrosternal goiters. We incorporated the post-thyroidectomy hypocalcemia protocol to assess the risk of hypocalcemia, and only patients stratified in the low-risk category were considered for outpatient thyroidectomy. We created a comprehensive unit-based clinical pathway to assess the risk of hematoma in partnership with the PACU Length of Stay Committee and Emily McCollum as our champion. This included the creation of a new extended PACU stay epic order set, an admission discharge algorithm, and measurement of neck diameter pre and post-op. Patients who were candidates for outpatient thyroidectomy were evaluated in PACU for 4 hours prior to discharge. This pathway also included a tracking form used by the nurses to call the patients the following day after outpatient thyroidectomy. We also developed patient educational materials and a patient test to assure patients' readiness for the management of complications if they were to occur. The materials also included a lifesaver card on a linear for quick access of the key information, phone numbers for direct access to care, and a sign and symptoms to call 911. For the implementation of this protocol, as for the implementation of the hypocalcemia protocol, it was paramount to have the support and buy-in of all our partners, as well to provide education to residents and staff of the new protocol. For this protocol, it was indispensable the partnership with the PACU Hospital State Committee and the hard work of Emily McCollum to implement the post-thyroidectomy extended PACU state pathway, as she provided education, monitoring, and feedback to the PACU staff. This protocol took place in 3 different care settings. In the preoperative ambulatory clinic is where the patients were selected as candidates for outpatient thyroidectomy by the application of the outpatient thyroidectomy candidacy criteria tool. Patients that were candidates will have a green sticker placed in their consent form, and those who were not, a red sticker. Also in this phase, patients who were deemed candidates for outpatient thyroidectomy received direct education about signs and symptoms and the management of hypocalcemia and hematoma if they were to happen while they were home. And their understanding of this was tested by the application of the patient test. If patients felt any of the questions, further education was provided until we assure patients' understanding of the signs and symptoms and what to do at home. In the intraoperative setting, in collaboration with anesthesia, protocols to prevent post-operative nausea and vomiting, the prevention of coughing during extubation, and EMG monitoring were used. In the PACU, risk assessment for hypocalcemia protocol was applied, and if the patients were stratified in the low risk, they will observe 4 hours prior to discharge. Also, the patient will provide further educational material and the lifesaver card. Post of day number 1, the PACU nurses will be calling the patients and filling out the tracking form. Emily McCollum presented the early results of the implementation of the extended PACU state pathway in the Rock and Mountain Evidence-Based Symposium, and her data show that of the 41 patients that were candidates for outpatient thyroidectomy, 23% were deceased at home, and 100% of those patients stated that they felt comfortable and safe at home. Of the 23 patients, 3 reported mild symptoms of hypocalcemia that resolved with additional TUMS during the post-discharge day number 1 phone call made by the PACU nurses. We further examined the outcomes of the outpatient protocol by evaluating 259 patients who underwent thyroidectomy, completion thyroidectomy, plasma and central neck dissection after the implementation of a protocol. Of those patients, 60% were deemed candidates for outpatient thyroidectomy based on the outpatient thyroidectomy candidacy criteria tool. Of those, 45% were stratified as a low risk for hypocalcemia and were candidates for outpatient thyroidectomy, with 82 of those patients being discharged home the same day. 40% of the 259 patients that were evaluated were not candidates for outpatient thyroidectomy and they were admitted. Additionally, 54% of the patients that there were candidates for same-day surgery, they were admitted because they were stratified in the moderate and high risk for hypocalcemia. Here is the list in order of frequency of the criteria for why patients were not considered candidates for outpatient thyroidectomy. The 3 most common reasons were goiter, anxiety, and obstructive sleep apnea. And multivariate analysis of our data, there was some suggestion that some of the selection criteria are important in predicting certain outcomes. As example, large goiter with the length of hospital stay of 2 days or more, substernal goiter with a hematoma formation, and a BMI more than 40% with an unplanned follow-up visit. However, This was not statistically significant. This table compares the outcomes among the patients that were admitted versus those that were discharged after the implementation of the outpatient thyroidectomy protocol. Here we can see that none of the patients that were discharged the same day developed hypocalcemia, neck hematoma, had an unplanned return to the ED, or required an unplanned readmission. All the complications that we seen were on the admitted group. 19% developed hypocalcemia, 2.5% had severe hypocalcemia, and 4.5% needed IV calcium. In the admitted patient group, 2.5% had a neck hematoma that needed a reoperation, 5.5% had an unplanned return to the ED visit, and none of those visits were because of hypocalcemia, and 1.6% had an unplanned readmission to the hospital. This data demonstrates that the outpatient thyroidectomy protocol enables safe same discharge while assuring admissions for those who develop complications after thyroidectomy. We also compare the outcomes of 193 patients prior to the implementation of the outpatient protocol when all the patients were admitted to 259 patients after the implementation of the aforementioned protocol, and we found there were no statistical significance on the rate of complications among these two groups, attesting to the safety of the outpatient protocol. An unintended consequence of the hypocalcemia protocol was that a 7% rate of mild to moderate postoperative hypercalcemia that were seen at the 2-week postoperative follow-up. These complications was only seen in the high-risk group, and as a response to this complication, the decision was to modify the initial therapy dose and its duration for the high-risk group in the immediate postoperative hypocalcemia algorithm as shown. For the patients with a PTH less than 1, we will start a calcitriol at the same dose as the prior algorithm, while for the patients that have a PTH between 2 and 10, we reduce the calcitriol dose by half, and also the therapy was dispensed for 1 week only compared to 2 weeks in the past. We need to analyze the data since this modification was done to the protocol. The outpatient protocol appears to be over-conservative, as only 20% of the patients that were admitted developed hypocalcemia event, 2% had a severe hypocalcemia, and only 4.5% needed IV calcium. Furthermore, the neck hematomas, which happened in 2.5% of the admitted patients, occurred within the 4-hour observation period and will have been captured using the extended thyroidectomy PACU-STAT pathway. All of this calls for the revision of our selection tool and admission criteria to identify more patients that can be safely discharged the same day after thyroidectomy. We have already added the moderate risk group to be included in the same day discharge. In summary, the standardization of care in the endocrine surgery practice allow the identification of patients that are high risk of developing complication and require closer monitoring, while allowing the transition to a safe outpatient thyroidectomy practice. I would like to thank my mentors and partners, Dr. Robert McIntyre and Christopher Rayburn, the support and strong collaboration of our endocrinology colleagues, especially mentioned to Dr. Ryan Howen and Nikita Pozosjev, our PACU Land of Stay Committee, PACU nurses, and our champion, Emily McCollum, to all the surgical residents for the strong work on following the protocols and the care they provided to our patients, to my medical student, Radhika Chandramoli and Brian Lauren, as well as to our surgical resident, Stephanie Davis, for the hours and commitment to collect and review the data, to the SOAR committee and Laura Helpkamp for the statistical support, and UC Health for supporting the development of patient educational materials in the Lifesaver cards. Thank you very much.
So Dr. Albuja Cruz, that was an excellent presentation. And I think only people who have been through this process can really understand, how a relatively straightforward concept can be so complicated when it comes to implementation. If you had to distill maybe the top 3 lessons learned from going through this process, and you could pick out of your presentation, what are the top 3 things you want people to be aware of when they embark on doing something like this, which, I think there are many opportunities in the Department of Surgery.
I think one of the most important things is partnership with all the people that will be involved in the project. I think the buy-in of all the persons is one of the most important things. The second most important thing is the monitoring of the application of whatever changes are made. One, to assure that it's happening, and second, to assure that there is no unintended consequences of the changes. And I think thirdly, data. If you don't have data, it's impossible to understand if there's an impact on the changes you're making.
Great, thank you. Dr. Kumbler, I noticed you had something on chat. Do you want to ask directly?
Yes, thank you. I think this is such a fantastic example of the application of quality improvement to surgery in order to not only improve outcomes, but also reduce healthcare cost. The question that I have for you is how you were defining success for the outpatient thyroidectomy protocol. One could imagine defining success as the complete absence of need to intervene after hospital discharge, or one could consider success to also include early identification of complications in time to intervene prior to harm occurring. Which definition of success were you using?
We were using the first one. We didn't want any of our patients to require further admissions to the ED or clinic visits, and God forbid, an hematoma that occur at home as our main endpoints. But I think moving forward, in order to be able to apply this to a farther population, we're going to have to assure that if allowing some of those things to occur while they're in a safety net, so in that way we can have more patients that can be served by this outpatient pathway.
Fantastic.
Okay, we have reached the end of the hour. Dr. Albuja Cruz, Maria, thank you so much for that talk. And I look forward to your next project after this one, has been put to bed. I guess these projects are never really put to bed. You have to keep monitoring. But we look forward to your next project. And again, I think for the entire department, taking on these quality and safety initiatives are so important. And I think they will define our department as to how good we are. And very important work. And thank you, and everyone have a great day.
Thank you.